So does anyone have any question for the last speaker block? Just a reminder from our colleagues from Arthur Ashe, our division directors, Dr. Hawthorne Smith and Dr. Chang. You can unmute yourselves or you can put some of your questions in the chat box. I'll ask a very general question to all of the panelists as people are gearing up with their thoughts. I think a lot of the work that you all discussed, clearly the topic of the day is immigrant health, but it really does apply to marginalized communities in our country, irrespective of their immigration status. And so I'm just wondering how, some of your work are specifically, for example, Dr. Hawthorne is specifically looking at survivors of torture, but how can we make some of these general principalities applicable to all of our patient populations that come to see us in the ED? Maybe some suggestions on that. We talked a little bit about cultural competency and humanism in the way that we care for our patients, but maybe some advice on how we can apply these topics even more broadly beyond the discussion of immigration.
Thank you very much for that question. And, as I train on these things and as I'm listening to the presentations today and realizing that when we talk about trauma-informed care, when we talk about the ways that we, try to adapt things for marginalized populations or what have you, that it's not really about one particular population. This is just good care, multi-directional vectors of empowerment, of communication. That's important no matter the person that's sitting across from you or the context. So I think that there are certain things that are really sort of highlighted and underscored in the work that we're doing with the migrant populations, the immigrant populations, and what have you, but it's just good treatment by and large. So again, I think that anything that we can do that helps others, stakeholders, funders, administrators to understand, once again, this is not some exotic other population, that these things we are talking about are things about us, our communities. And even if someone comes from thousands of miles away and speaks another language and is in our community, this is a question about our community and how we're living, how we're healing, and how we're moving forward. So I think that that notion of inclusion into the conversation, people having a seat at the table, having a voice in the conversation is extraordinarily powerful. And unfortunately, I think that sometimes it can be an uphill struggle upstream. I've had conversations recently, the way that we do things within the Francophone African group. And is it truly group psychotherapy, or is it more, is it a travel log? Are we just discussing, pertinent issues in Burkina Faso or Democratic Republic of Congo? It's like, no, these are people who are going through stressors, either immediate in front of their face or with their extended family and all of these things. And how do we empower them to engage with us, to help guide us? How do we earn that precious gift of trust that we talked about? All of those things together, that doesn't, if I'm sitting next to another straight, cisgender, Black American man from the Northeastern United States, pretty much my tribe, I need to put all of those things into place anyway. It's not about the population. It's about the relationship. It's about the engagement. How do we really make that effort to not otherize the others? I think that Umberto had said that before, and make sure this is a question about our community, which is much larger, I think, than oftentimes we give or we're allowed to think of it as being this large a community. So I would just start there because I want to hear what the other speakers would have to say as well.
This is Umberto. My brother Hawthorne, congratulations. I really like your presentation and the recent presentation by the sister out in California, because I think they address the complexity of the matters that we're facing. I also do a lot of UN work, and I always say the UN has a perfect society. It's written very well. all the policies are written, all the good definitions are written, the concepts are written, but the quality of life for the majority of people continue to remain the same. So the question for me is, are we discussing, the analysis, the evaluation, or are we collaborating to kind of find some action, some intervention to make a difference in how we address health as a human rights, right? Which is, I think, is the original point we were making. I would just say that I think, not being from this country originally, that in the US, the idea of discussing policy without discussing politics make it a problem. In any other part of the world, where I'm from, Latin America, people want to know your politics. What do you think? What kind of society you want? What do you understand of justice and democracy? Because that's going to tell me your policy. We're in a very delicate moment in this country where there's a lot of politics of hate, discrimination, that the recent presenter just document the historical repetition of those form of exclusion and dehumanization of population. And I think this conversation is relevant where we have to apply where we are today, what are the threats we're facing in this population, and what are we recommending in relation to integrating a different approach from the emergency room to all aspects of care that we're facing. And we share that from a community perspective because one of the things make it difficult to do work in a community is that our community look in your eyes to see if you're a truth teller, if you're courageous enough to say those things that no one else want to say. That is one of the things that make it hard for us to do. And I want to end this comment, as I'm from Latin America, I said, spent a lot of time in Central America. During the 80s when they had the war in Nicaragua, El Salvador, Guatemala, the people who are coming here now, a lot of those people were traumatized because of a lot of US foreign policy supporting those dictators. When that population end up here, we had to find an alternative way of treatment in churches and in community base, because when they went to the emergency room, they were re-traumatized by the type of question by doctors who was also part of the US military and trained and saw them as enemies and dangerous and communists and terrorists. And I raise this because that's the real world that we face. And I think that we have to be aware of some of those difficulties. We're not going to have all the answers, but at least we have to be sincere of the challenges that we face. I want to congratulate Teresa Smith, who I've not known personally yet, but I think that this is a good initiative for people to start talking and unraveling some of the difficulty that we're facing, but we do it in silence, implementing policy that we know are limited, and not opening a truthful, engaging conversation. And I'm happy to be participating in this because I think for us it's been useful to see all the different aspects of what we're facing collectively. And we are believers that universal health care is the answer, integral care that includes everything. One of the areas I'm recommending that we pay attention to, I think the last speaker spoke a little about it, is that people are looking at social determinant more from some of the other aspect of it. There's a new study from the World Health Organization about commercial determinant of health. And in those studies, they're showing that the most powerful influencer of health as a private sector, the transnational corporation, the corporation, which you define in policy, politics, and defining what government can respond to or not. So I think we have to, even the World Health Organization is starting to look at other players in the issue of the outcome of health. And I think we need to incorporate that to understand, because we're missing one of the most fundamental determinant, the policy that's imposed by the private sector, if something is acceptable or not, even though we think it's the right thing to do. So I'm calling our attention that we continue to navigate and look at some of those obstacles and be courageous enough to at least have the conversation about it.
Thank you. Thank you. We have two questions, and I actually have a final question as well. So this is a pretty loaded question, so I will ask some of it. How can we scale these efforts to better coordinate care, which I think Umberto just kind of addressed, and also addressing some of the obstacles. Is there legal work or policy? Is legal work or policy truly the only way? And how realistic is it to expect physicians to take a policy and make it at a grander scale? So I think what this physician is asking is, what can we do as the individuals, right? We talked about the system, the institution, but at the individual level, what would you suggest?
I can take some of that. And I see the other question from Sabrina about getting involved, especially given political challenges.
Yes.
And feeling hesitant about navigating political aspects. Look, I'm going to say the other half of this talk, it's a much longer talk. The other half is about community organizing and movement building, and that we don't do this alone in the healthcare sector. We have to make partnerships. We have to create movements. And particularly for me in community health centers and the federally qualified health center arena, community health centers were born out of the civil rights movement. And so that is intrinsic to the work that we do. My health center, the first 4 words of our mission statement is to serve and advocate. Okay, so dual mission, service and advocacy. Because if you're just doing service without looking at those political or policy or structural dislocations, then you're just doing charity. And for me personally, I'm not about just doing charity. I'm about community capacity building, empowerment, having a strong community, having strong people and citizens who are civically engaged. And so when we talk about this work, the other half of the talk is about community organizing. We didn't have time to talk about it today, but that's really important, right? So in the civil rights movement, it was Martin Luther King Jr. who said, Dr. Martin Luther King Jr. who said, that it was inhuman, right? That lack of healthcare was inhuman. But the sentence before it and the sentence after it talked about using federal funds to enforce this sort of inhuman and segregation of healthcare access, right? And then it was in the Black Panther Party that one of their 10 points in their 10-point plank was to provide healthcare for the people. And so it's movement building. It's about being civically engaged. It's not about a doctor writing a policy brief and then, doing this in isolation. That's not what I'm talking about when I talk about getting involved in policy and advocacy. I'm talking about our systems getting involved in policy that is going to increase access to care and protection for our patients and our communities. And so that means our organizations, our national associations, working with other sectors, and moving policy that way. So it's movement building. I hope that helps. And then in terms about navigating the political aspects, you know what, I'm not navigating political aspects because if we're afraid, imagine how much more afraid our patients are, right? And we have education, we have a platform, we have voice, we have financial resources. And so, I don't think about that too much. I think about focusing on the truth of what we see in our experiences, and no one can argue with the experiences that you have. They can argue about how they're going to fund it. They can argue about, all these things, but the kernel of truth there, and the truth is that what our communities and our patients are experiencing. And if you always bring that to the table, if you always bring the community and the patient voice to the table, I mean, you have a full foundation to stand on.
Right. Thank you. Thank you very much.